going to just give allowance for a couple of minutes more for some of our usual attendees to join us as people sort of like finish off what they were busy with before. So just a couple of minutes more. Thank you very much indeed. And before I introduce all our speakers, our focus today is palliative care. Just another minute and then we'll start. Right, it is indeed my pleasure today to introduce to you our speakers. We are focusing on palliative care, and it is a topic that I think is very close to everyone's heart as we are working in cancer care in Africa. So our first speaker, our didactic speaker, is Dr. Megan Doherty, palliative care consultant for the World Health Organization. Dr. Doherty is currently the consultant in palliative care, and she's a palliative care medicine physician, originally from Ottawa, Canada. And throughout her career, she has worked in a wide variety of settings globally, developing clinical palliative care services and training programs. She previously served on the executive committee of PalChase, and she worked to establish models of palliative care suitable for humanitarian settings in Asia and Africa. Dr. Doherty has been involved with the development and implementation of leadership and education programs through her work as the Pediatric Palliative Care Program Director for Two Worlds Cancer Collaboration. She is passionate about developing tools and guidelines to support greater implementation of palliative care with primary care and universal health coverage. Megan, over to you. Thank you.
Thank you very much, colleagues, and it's so wonderful to be with you. I had the honor of being invited to support the Impact Mission in South Africa last month. And so it's been a wonderful experience to see and experience some of the continent and the challenges and the work that you're doing. So I want to just share my slides here. Sorry, there we go. And as Salome said, this is such an important thing is really how do we integrate palliative care into cancer control and cancer planning? And this is, you have the opportunity to do this if you're a cancer planner or if you support cancer planning. And the question is, how do we do it well? Because the good news is it's worth it. It will help you. If your goal is, better care for people who have cancer, improving survival, saving the system money, matching better spending with needs. Palliative care checks all of those boxes. And so that's what we're going to talk about today. So I hope after today, you'll be able to define palliative care and explain how it really is an essential component of cancer planning and cancer control, describes the needs and the benefits for palliative care for both patients and families, as well as health systems, analyze the ways that you can integrate palliative care into cancer care to optimize the outcomes for patients, and then really describe how you can optimize your health system to integrate palliative care well. So I wanted to start with a story of a patient, and I'm sure you can think to many patients that you've seen who are similar to this. I've kind of created this from patients that I had myself experienced. So think about Maria's story. She's a 68-year-old woman. She's living in a rural village where she has advanced breast cancer. She was diagnosed 3 months ago at a district hospital 2 hours from her home. But the hospital had no palliative care service, and they just discharged her home because she wasn't fit for any cancer treatment without even any instructions for pain medicines. Now she's really spending most of her time in bed because she has severe pain, and the only medicine that she has is paracetamol, which is really not helping. Her daughter has stopped working, stopped her job in the market to stay home and care for her mother. The son had to borrow money for the first hospital visit, and there's not money to go back. And the feeling is that even if they went back, the hospital wouldn't really know what to do to help her. And last week, Maria told her daughter, "I'd rather die quickly than live like this." And we know this is the situation for so many of our patients, that they are abandoned by the health system when they have incurable cancer. And we can change that narrative, and that's what we're going to talk about today. We know worldwide more than 70 million people need palliative care, and unfortunately, very few are receiving it. In Africa, last year, there was the release of the Palliative Care Atlas in Africa, and this showed that 17 million people in Africa need palliative care. If you haven't seen this atlas, if you scan this QR code, you can download it. It's freely available online. And I encourage you to do that because it gives a snapshot of every single African country about what's happening for palliative care in your country. So this is part of that first step you have to do as you start to think about how you integrate palliative care into your system, is to say, where are we at right now? What are the needs in our country? How many patients need palliative care, and how are we going to plan the system to match their needs? So what is palliative care? I think that's where we have to start from. WHO has produced a number of guidance documents and a definition of palliative care. Most simply put, palliative care relieves suffering, focuses on improving quality of life for patients and their families facing a life-threatening or life-limiting or serious illness. In a little more detail, in the WHO definition, we say it focuses on improving the quality of life for patients and families facing the problems associated with a serious illness. Ensuring pain and other symptoms are controlled is such a critical part, but also relieving suffering through early identification, assessment, and treatment of both physical, but psychosocial and spiritual concerns as well. I think there's some key principles that really match with the work that we all do caring for people with cancer, right? Palliative care is holistic. So it doesn't just look at what are the physical problems a patient has, like they have pain. It also thinks, what is the psychosocial and spiritual aspects of the illness experience? And we know that to give that kind of holistic care, you have to identify patients early, assess them, and then treat those problems. And I'll talk a little more about how we do that. We have to have continuity of care. The patients who have the most encounters in a health system are the patients who need palliative care. They are like ping pong balls. They go to tertiary hospitals. They get diagnosed with cancer there. Then they flow down to district hospitals. Then they go home. Then they have poor symptom control. They have terrible pain. They ping pong back up into the hospital. So they are constantly moving around the system, which means you have to think about how you ensure they have continuity of care. How do they get the same care and the care they need across your whole system? You need to think about integrating palliative care early into the course of their serious illness. It is not just end of life care. It can be combined with treatments to prolong life and cure illness. And we know that it is very clear, there's strong evidence now that you should not wait and delay or give palliative care only at the end of an illness or when you can no longer cure the cancer. They've actually shown that it is more effective to start palliative care at the time of diagnosis because patients will actually live longer if you do that. And the care, thirdly, must be patient and family centered. So you have to think about what matters to the patient and their family, not just what can the health system deliver and what are the problems we're trying to fix, but what are their needs, their preferences, and their values. When we say holistic, we've talked about, physical symptoms we address like pain, vomiting, breathlessness, that emotional experience of the illness, spiritual needs such as feeling a sense of belonging, repairing relationships, searching for meaning. And also important areas are practical supports, helping people live as well as possible with mobility aids, with adaptations, with supports they can stay at home, and effective communication as the cornerstone of that. Because if people don't understand what's wrong with them, about their disease, about its prognosis, they can't make good decisions. They can't make decisions that reflect their goals and values. So let's have a little bit of interaction. It's maybe afternoon and you're getting a little sleepy after your lunch. So let's look at these statements, and one of them is true. So I want you to think about them and select which one you feel is true, and you can put your vote in the chat. So palliative care should start when there are no more curative treatment options available. Palliative care should start when the person's estimated life expectancy is 6 months or less. Palliative care should start at the time of diagnosis and be continued throughout the course of illness, whether the outcome ends in cure or death. Or palliative care should start when the person can no longer afford treatment and requires financial support. So think about what you think is the correct response. There's only one. And if you want to vote in the chat, you can do that. Great. So I'm seeing people voting. That's good. Gets you active, gets you engaged, thinking about it. And you are right. It is number 3, right? So I want to emphasize this is probably the most important thing for you to take away. Palliative care can and should be provided alongside regular medical care. It's not like an either or. It's together. This diagram, I hope, is clear, but this is at the time of diagnosis for the patient when they might be getting a lot of this yellow treatment, which is disease-modifying treatment, like, for example, chemotherapy. But we know they still need some palliative care in there, right? They might start to have a lot of pain, and so they could get some palliative care. Maybe if they get pain management, their palliative care need goes down a bit. But gradually over time, if their illness is progressing to the point where this is a life-limiting illness, they will need more palliative care. This is the time when the patient dies. And then here you have bereavement care, right? The family still needs that grief and bereavement support after the patient dies. So this can be a helpful way to conceptualize the idea of integration. And like I said, there's robust evidence to support this. There's been 2 systematic reviews showing that palliative care is better at the time of diagnosis and throughout the illness than just as needed or when you think the patient needs it. So it's highly recommended to integrate it early. Again, this is just the same thing. WHO has produced these nice social media tiles with some of these ideas on them. It's not just about the end of life. It can be considered early in the disease to help improve troubling symptoms. Again, that goes back to the fact that what matters most to people. Living as long as possible is not everybody's top choice. Think about Maria. If you're living a longer life, but you're in terrible pain, that really isn't a life most people would choose. So there are 3 main areas to think about in terms of the benefits of palliative care. It really is a best buy in the health system. It's cost effective and it really reduces a lot of suffering. So let's look at these 3 key benefits. First one is improving health. I think this is quite obvious. You manage symptoms for patients, they're more comfortable, they have less suffering. We know that we have lower rates of abandonment from cancer treatment if you give palliative care because their side effects are well managed. The patients are better able to actually follow the treatment plan that the oncology team is providing. Second area is thinking about protecting people from financial risk. So palliative care reduces costs for patients and families and it minimizes out-of-pocket expenses. Because if you talk to the patients and help them understand what's wrong with them, what the disease is, what the chance of it being cured are, they make better choices about what they're going to do. So the main issue is that there's a mismatch in the understanding of the patient and family and the healthcare team about what's going on with the patient. And with palliative care, you reduce that mismatch in understanding. The other thing is, if you have palliative care in the communities closer to home, you reduce your costs for hospitalizations and emergency care, both for the health system, but also for patients, because there's less loss of income, the cost of transportation and lodging, and the cost for the family caregiver to be at the hospital with the ill person. And then it improves health system efficiency. Remember I said palliative care patients are like ping pong balls, they're going all over the system. So if you do palliative care, you have to think about how you coordinate your system, how you make sure the services are logically arranged from the tertiary to the secondary and the primary care level. So your treatment plans become more effective and patients follow them better. Like I said, better understanding of their disease and support helps patients make better choices about the care that they want to have. So you actually reduce in your system the use of high intensity, aggressive care at end of life that actually isn't providing any benefit. And we know this is very expensive care sometimes. For example, chemotherapy in the last 7 days of life is probably for most patients a waste of money, right? Because it doesn't prolong your life. It's too close to the time that you end up dying. So we know that that's an indicator of a high intensity treatment that has little benefit. But if patients understand better what's going on with their illness and there's more open communication, then we don't get that mismatch there. What do we have to support from WHO side related to helping you plan your health system for palliative care within cancer control? We have a resolution on palliative care. This calls on countries to have palliative care policies to support the integration of palliative care. So this means your cancer control plan should include mention of palliative care, and not just token mention, but actually outlining how you will deliver cancer care for patients and palliative care for patients who need it, who have cancer. Calls on countries to fund and allocate human resources for palliative care and to provide training for those human resources for the doctors and nurses who make the system. And we have a model to sort of explain how does this all fit together? What are all the things you need to think about to build good palliative care in your health system? There are 6 things. You can see them here. You need to empower people and communities. You need to get them involved in saying what matters to them and how and where they want care for their loved one or themselves. You need the health policies, like I said. You need research done in your own country that really defines, what is the needs of patients in your setting and how do they need to be treated. You need to think about essential medicines for palliative care. I'll tell you more about that. Training for palliative care for health workers. And finally, if you get all these things right, the blue, the yellow, and the green, then you can put the roof on your house and you can actually deliver palliative care. And you can cover those patients in the middle here. This is imagining the patients are here inside the house. You can cover them with palliative care. This is a video. I won't show it, but it explains that same idea. It's about 2 minutes long from WHO, and these slides will be shared, so you're welcome to watch that. So let's think a little bit more about how we do this. How do we integrate palliative care? It's an essential component of cancer control, right? Every cancer plan should have palliative care in it. And it should be woven into the whole system at cancer centers, at tertiary hospitals, then at your district or general hospital level, in primary care and in community and home-based care. And we know that we have created from WHO a core set of palliative care interventions that healthcare workers can do after just basic training. And this is our palliative care service package. Okay, it can be made available at the first contact health level, meaning within primary care. It's comprehensive and it's not fancy. It's available in low resource settings, and it can be applicable across the life course, meaning for children and adults. If you want to see this package, This has been designed by WHO, validated, peer-reviewed, and it's a robust package that we encourage countries to consider when they're planning for palliative care. You scan this QR code and you can explore all of our health packages and specifically the one for palliative care. We know that the health workforce needs to be trained to provide palliative care, like I said, and most have not been trained, right? Most countries, the training of doctors and nurses does not include palliative care, right? It's not a mandatory subject in their undergraduate training. But without that training, health workers don't recognize patients who need palliative care and they don't know what to do. So they ignore it and they don't have any concrete things they can do to help people. We know there are really three core actions that generalists or non-specialists can do to provide palliative care. First, they need to identify and assess patients and see that they have palliative care needs and figure out what those needs are. And that's done through a standardized approach. And then you can have the management of common palliative care symptoms. Again, WHO has defined those. And then the idea of the coordination of care so that the ping pong ball, as I said, you think about how it's going to flow through the whole system. I want to highlight community health workers as being quite a key role. They could really help somebody like Maria, who is wanting to have care at home. She's not in a hospital. How do we make sure she has care for her serious illness? So let's imagine that Maria doesn't live in a place without palliative care. Let's change her story. She is now living in the village with her daughter. She's had breast cancer, but she's able to access pain medicines that control her pain because she has a trained community health worker who monitors her regularly, visits her at home. And in one of these visits, Maria tells the community health worker her pain's a lot worse. You can see here in the picture, the community health worker makes a call to the supervising nurse at the local primary health care center. Based on that report, the nurse arranges a home visit. She evaluates Maria's pain and determines that her pain medicines need adjustment. She contacts the physician on the phone. They prescribe a new dose of pain medicine. And that new medicine really helps Maria feel better. And the team follows her up. The nurse is trained. She visits and checks on Maria by phone, and Maria's pain is much better. And she doesn't have that response of saying, I wish I could die sooner because I'm in so much pain. So you can see how it is possible. It does link to this idea of essential medicines. As I said, we've defined from WHO an essential package of palliative care medicines, and health workers can safely prescribe these after basic training. I'm not going to go into it in detail, but this is the list of those medicines, and you can find it again through that QR code I shared. And I will highlight that ensuring safe access to morphine is one of the essential medicines for palliative care. I can't go into it in more detail today, but if you scan this QR code, you can hear about Uganda's story on improving access through local production. And so there are additional resources to help countries plan for how to have access to opioids, which are controlled medicines. There are a core list of basic equipment that is inexpensive and simple to use with basic training that is required to deliver palliative care. It's listed here. I won't go into it in detail. And then we talked about how service delivery needs to be at the community, at the general or the general hospital, outpatient, primary care level that has different names in different systems, and also at the hospital level. To support all of this, WHO has a whole package of guidance on palliative care. If you scan this QR code, you will access a PDF document that lists all of the different guidance that we have. And I think I'm close to the end of my time, so I'll just show you a couple of the key resources that we have produced that will be relevant for cancer control and planning. So WHO has produced pain management guidelines for both children and adults. WHO has produced fact sheets that you can share with parents about what is palliative care for children. There's 8 of them, and these are available in English, Spanish, French, and Portuguese. We also have the National Cancer Control Planning course, which is available on the WHO Academy for free. Anyone can sign up and have an account. And this course tells you how to plan for cancer, and it includes how you integrate palliative care into that process. We are preparing and soon to release a specific course on service planning for palliative care in more detail, which links to that health package that I told you about for palliative care. And we have produced a series of 5 guidance documents for health system planners about how to integrate palliative care into various things, including, I would highlight, this, which is about setting up a comprehensive cancer center and includes a chapter on how you integrate palliative care into your cancer centers. And this, which is about, how you integrate palliative care into pediatrics, how you integrate palliative care and pain relief into primary care. So these may be of specific relevance. They're all available through that QR code I showed you, and I will come back to the QR code at the end. I would highlight that we also have the WHO Palliative Care Working Group, which is a global group which includes members from your region. And this group meets every year in person and works online continuously throughout the year to push the global movement for palliative care and support the integration of palliative care. And so that group is behind much of this. So let's wrap up now. And let's see if you remember a few things about palliative care here. And I actually realized that I took out the slide that had the answer to this before, but let's see if you know the answer anyways. So which of the following statements is true? Palliative care is accessible to at least half of the patients who need it in most countries. Only 14% of people who need palliative care worldwide actually receive it. The majority of people needing palliative care live in high-income countries, and all patients who need pain relief can access it. So which one do you think is true? You can put it in the chat if you would like. Good. So most people are seeing B, which is correct. Yes. So worldwide, only 14% of those 70 million, it's actually over 73 million people who need palliative care are able to receive it. Thank you. So I'll just show you my summary slides as a final. So I said I would tell you what is palliative care and how it's an essential component of cancer control. So we talked about it being the relief of suffering, not just at the end of life. And we showed that graph of how it should integrate. And I had this slide and I actually took it out. This is the one that shows that 86% of people who need palliative care don't receive it, meaning only 14% of those who need palliative care are able to access it. Only a small percentage of the world's population has access to pain relief, and for children, the needs are even more severe. We also describe the benefits of palliative care for patients and families and for health systems, improving health, improving relief of suffering, financial risk protection, both for patients and families, but also for systems, and health system efficiency. And really that's based on early identification, early initiation, and integration of palliative care for patients, not just when you realize they can't be cured. And then thirdly, we said we would analyze the ways that we can integrate palliative care throughout cancer care. And of course, I could speak to you about this for many hours, but I gave you just a high-level overview thinking about the system and how we can integrate and how we need to build each of these 6 building blocks to really ensure patients have palliative care in cancer care systems. And I described some of the key supports that WHO provides. I mentioned about the health packages for palliative care with the essential list of medicines and supplies. And this can be very helpful if you're planning for cancer and palliative care within your health system. And then the service implementation guidance, particularly the one on setting up a comprehensive cancer center, which I thought would maybe be more relevant for many people who are cancer specialists or cancer control planners. And again, I'll leave this slide up as the last slide for a moment because this link, if you scan it, you will get all of the WHO guidance related to palliative care. So I'll stop there.
Thank you very much, Megan, for an incredibly well presented and slide about what palliative care really is all about. And I want to congratulate you and your team for the work that you've done in terms of providing these resources, specifically where we are battling to actually implement palliative care. And I think without these resources, we definitely will not be able to do so. Obviously, there's lots of other, as you say, system issues that we need to address. And I think every country is different. Obviously, every country is different depending on whether we have the resources. But more importantly, the fact that we also are starting to focus on the role of community health workers and our traditional health practitioners in terms of the role that they play with regards to palliative care. We're going to allow for questions and answers afterwards. So I want you all to keep your Keep your questions, just hold on there for a bit. And then it is my pleasure now to introduce to you Dr. Mpho Ratsikana, who is the director of the Wits Center for Palliative Care. Dr. Mpho is the director of the center at the University of Witwatersrand and is a palliative medicine specialist with expertise in palliative care research, program development, and capacity building. Her research focuses on palliative care needs, quality of life, patient outcomes, and improving access to palliative care, with a particular interest in spirituality and religion in serious ill careness. She is the co-principal investigator of the Soweto Comprehensive Cancer Care at Chris Hani Baragwanath Academic Hospital, which is the biggest hospital in Southern Africa, and the principal investigator of the program Strengthening Palliative Care Services across Charlotte Maxeke, Johannesburg Academic Hospital, the Soweto Comprehensive Cancer Care Center, and Helen Joseph Academic Hospitals, all hospitals within the Gauteng region. She teaches undergraduate and postgraduate students at Wits University and convenes professional short courses in palliative care and spiritual care for healthcare professionals across South Africa and other African countries. She has held several national leadership roles, including serving on the Committee for the Development of South Africa's National Policy Framework and Strategy for Palliative Care, and continues to contribute to research, education, and policy development in palliative care. And she's going to share with us her experience with regards to palliative care in her setting. Thank you, Mpho. Over to you.
Apologies. Good afternoon, colleagues. And thank you very much, Salome, for the warm introduction. I believe we did the echo upside down, but I think it was the time difference on my side. I had forgotten that there is a time difference between ourselves and Kenya. So I was requested to talk about the palliative care and cancer survivorship in Africa, focusing on case stories, and I'll also indicate what we do here at Chris Hani Bara. So this is my presentation. I'm trying to move the slide now. Okay. This is the outline of my presentation. I'm hoping that I have about 20 minutes, I think. I hope I'll be able to finish. And I just wanted to start with a bit of background to give context on the palliative care survivorship within South Africa. I think we're all aware South Africa has a very high burden of HIV. We also have a very high burden of cancer. And our health system is divided into two. 85% of the bulk of the population receives their care from the public service, and the 15%, remaining 50%, is able to afford private care. So this is how our system, our health system is arranged. However, when someone who has been affording private medical care, when the benefits of the insurance gets finished, they then end up in the public service. So the public service is overwhelmed. Most of the patients who are presenting within our setting present very late. The cancer is already advanced. And when you look at Gauteng as a province where we are based, we have close to 17 million population. We have a lot of challenges on cancer care that I think Salome is well aware of. So the need for palliative care is very high. I have a map there that is showing the two areas. We have cancer services in Gauteng. We have 5 regions or 5 districts, but cancer services are actually centralized in Pretoria and also in Johannesburg. And up to a few years ago, Chris Hani Bara, where most people are not aware of, Chris Hani Bara did not have cancer care for solid tumors, adult solid tumors. That's why it became important for us to try and access private funding to start the services for adult patients. We all know that patients who are living with cancer require palliative care. Policies are there. We also know that palliative care is part of the universal health coverage. And I have two quotes here that I want to emphasize. The Human Rights Watch says that please do not make us suffer anymore. So I actually thought, I'm hoping that I'll be able to also share this with my doctor colleagues so that they are able to realize the impact or the negative impact of us not implementing palliative care. And they are also saying that doctors who are aware that cancer pain can be controlled, but they are not doing it, are actually considered to be torturers. So I don't want to be considered a torturer. And Merriman published a document, I think in 2018, where she was hoping that by 2023 in Africa, 50% of cancer patients would be accessing palliative care. I don't think we are there yet. So access to palliative care is still limited across different African countries. So in Gauteng, again, there are two hospitals that are actually providing, three hospitals that are providing cancer care. We also have, palliative care. I wanted to say palliative care. There are two hospitals that are providing palliative care. Okay. We have the Association of Palliative Care Centers, which is unfortunately not fully funded for them to be able to provide the services that they offer as inpatient units, for inpatient units, and also for home care, because home care is also not easily accessible for patients in our setting. Okay, so in Chris Anibara, or at Chris Anibara, a few years ago, we had an MSc student who looked at early referral of patients for palliative care, cancer patients for palliative care. And despite the fact that we've been in existence for more than 25 years at Chris Anibara, specifically, only 17% of patients were referred within 90 days. And remember that patients here are presenting late. So I'm going to start with this case that was we saw in 2025. The young man presented in 2026 after he was kicked. The history says he was kicked in a football match, and he decided he ignored it for some time, developed pain. And when the lump now developed, he then went to one of the hospitals in Gauteng. The diagnosis was osteosarcoma, and the treatment plan was for him to be amputated. He was discharged, and he was supposed to come back. He never pitched up to at the hospital. Okay. And then in 2025, he presented at Chris Anibara. He's now 19 years old, and he was referred by the surgical team. He presented with this huge, fungating, smelly mess. He was in distress, and the plan was amputation, and the poor gentleman was distraught. And because the surgical team knew that there was palliative care, they then referred to palliative care. And this is what the team was able to then identify on the patient. Physically, he had that severe pain, fungating smell. He could not sleep. He was tired. He could not move because the mass was huge. Socially isolated, he could not go to school. He missed his friends. He was isolated, but he had a very good family support. He felt stigmatized. Emotionally, he was withdrawn. He had a loss of interest in everything that he was supposed to be doing. He was depressed, and he was also anxious. And because we have a team that looks at the holistic assessment, the spiritual component, because we have spiritual counselors, we're able to look at this, and this is what they got. He's a Christian. He's been going around for the past 3 years since the diagnosis. He was going from church to church. He was Christian, but also had traditional beliefs. He consulted numerous traditional healers who told him that he was kicked, and whoever kicked him had moti, so he's bewitched. So he was told to do numerous rituals and thought he would be healed. Unfortunately, nothing happened. And he felt abandoned by both God and his ancestors. So then he presented, and the team was then able to address his needs. And I think I'm happy to say that eventually he agreed to the amputation. He is being followed up. Unfortunately, the cancer was already spread because it was now 3 years down the line. So now I want to present the the model that we use at Chris Anibara. We have also, because we supported Charlotte Maxeke, we've also recommended the same model to Charlotte Maxeke, because if we are doing palliative care, but you lack some of the legs of this table, you are not providing palliative care. Okay? So we are a center of excellence for palliative care, recognized by the Department of Health in Gauteng since 2008, and we have all these responsibilities. We are also a center under the university. We are supposed to provide training, we have to mentor, we have to do research, and there's a lot of advocacy that we also do. And I think that's why one would find themselves and committees national to be able to provide services. The policy, South African National Palliative Care Policy, has all these models, and I had Megan present the different models that WHO recommends. So these are within the palliative care policy. Our policy currently expired in 2022, was extended to 2024. So we are currently reviewing, and we're hoping that it will be approved soon. I've highlighted the palliative care outreach services there because we used to provide palliative care outreach. We used to see patients in the homes, but that's not the responsibility of a tertiary or a central hospital. So we were actually doing what we were not expected to do. And management of the hospital did not agree with us. Eventually, we were supposed to hand over to the district health services. So this is what we do. We have these 5 legs, which are our objectives, and our services are nurse-led, doctor-supported, because we don't have enough doctors to be able to see all the patients. So most of the patients are seen by the nurses, and the doctors will then support. The doctors in the wards will also support nurses and do the prescription after they have recommended. We have trained palliative care physicians, we have trained palliative care nurses, social workers, psychologists, and spiritual counselor. Everybody has been trained in palliative care, and almost the whole team has also been trained in spiritual care because we don't have enough people to be able to provide the spiritual care. So the funding for the VEST Center for Palliative Care is actually mixed. Most of the employees, the doctors, the nurses, the social worker, one social worker, is paid for by the hospital. So it's a government-funded program. And then because we understand that Bara is quite huge, we have 3.4 beds. So the nurses and the doctors will not be enough. So we have extra private funding that assists us to be able to have an extra doctor and also have nurses and also pay for spiritual counselors because they are not part of the establishment for the Department of Health. Okay. So I also wanted to give just a clinical context of what it is that we deal with. This is what the Soweto Comprehensive Cancer Center deals with. And I'm highlighting here the 31 and 35% because it's stage 3, stage 4. So you realize our patients are presenting late. So it doesn't make sense for only 17% of patients to then be referred to palliative care. And then on the right is the snapshot of the patients that we see as a palliative care unit because we see a number of patients. And when you look at this, you realize the bulk of the patients that we see, 76%, are cancer patients. But I want you to look at what I highlighted earlier, the burden of cancer and HIV within South Africa. So all this is HIV, all this is cancer. So when you look at patients who are HIV positive, most of them, 77% of them actually have cancer. They are HIV positive, but they have cancer. So the burden of symptoms that they have is quite huge. So looking at the barriers to access to care for our patients, both for survivorship and also for palliative care, I used the Fortney model of access because I just wanted to check what do we get within our setting. Does it really fit into what it is that he suggested to the VA, the veteran, those who are looking after veterans in the US? This is the model that they use. And it has 5 components: the geographical, temporal, financial, cultural, and also the digital. Okay. So when you look at the geographical challenges that our patients have, the distance to facilities are a major issue. Patients who are coming to Chris Bara and eventually referred to palliative care are actually from Gauteng, but the bulk of the patient are actually outside Gauteng. So they're referred from Northwest Province. They would come in with buses in the morning, and the bus, if you are not admitted, the bus will take you back to your home, some 3-4 hours away. If you are admitted, you'll then have to be admitted. But now, when the patient is discharged, the patient has to go back to their own province for treatment to continue. There are no services. There are no palliative care services. There's no support for survivorship for this patient. So distance to facilities becomes a major issue. And then how are patients also coming to the facility? They use taxis. If the patient is bedridden, it becomes a problem. The family has to then try and get money for them to get this person in a buggy for them to take them to the hospital. Okay. Outreach and home care is limited. Currently, it's only provided by the hospices or the Association of Palliative Care Centers. But our situation is unique at Chris Bara. If you know the hospital well, you will know that the distance from the Soweto Comprehensive Cancer Center, where most of the patients are treated, is right at the entrance of the main entrance of the hospital. For you, a normal person, not sick, to walk from there to the palliative care unit takes you 20 minutes. So a sick patient cannot travel that distance. So geographical, even within the facility, is a problem. Then you have the temporal issues, which relates to the waiting time, diagnosis, your treatment. Some of the patients would be given chemotherapy. They have to sleep because chemo came late, and the chemo has to be taken now over 3 hours. So it's a problem. The patient now has to remain without planning, has to be admitted. Okay. One of the biggest challenges I think that the government has been taken to task with is the timely availability of treatment, chemotherapy, and especially radiation therapy in Gauteng. We only have 2 hospitals that are offering radiation therapy in Gauteng. So patients from Chris Bara will have to then go to Charlotte Matrix because the nearest is 20 kilometers away. Okay. And then the other challenge that we have is that there's lack of integration of palliative care within the oncology unit. Some of it is because of lack of space. Some of it is because the doctors just do not understand the need for palliative care. So as far as I can remember, medical oncology does not include palliative care as part of their training. Radiation oncology, who are trained in both radiation and chemotherapy, at least have some training on palliative care. Then there is also a challenge where there is I'll call it a disjoint between what the policy says and what we are practicing. There is a SPECT tool. I think Megan will know the tool. SPECT, it was developed in Edinburgh University. It was adapted in low-income settings. It's also adapted in South Africa. And it says for cancer patients, only advanced cancer patients should be referred for palliative care, which is a problem now because doctors will say, but this is what you are saying. The policy is saying, WHO is saying patients must be referred at diagnosis. Diagnosis for us in South Africa means patients are coming at advanced stage anyway. So it doesn't make sense for you doctors to wait until they discharge the patient before they refer them for palliative care, for us to be able to make sure that patient is well supported. Then there are financial issues. I will not go into this because we are in a poverty-stricken country. So this becomes a problem for most of our patients, and they need to balance. Do I get money for food? Do I take this money and go back to the facility? Okay. So there is, again, an issue of access to medicine and supplies. They are not easily available. If a patient requires nappies and all that, we cannot prescribe nappies from the hospital. We are expected for patients to be able to make sure that they get nappies, or families to be able to make sure that they have nappies. We still have issues of availability because of stockouts of medication that patients require. Then there are cultural issues. The cultural issues are big. We have this part here, religious and spiritual beliefs, that is impacting. One, when the patient presents to facilities, whether the patient will come back to follow up. The case I presented earlier, you'll realize that the 3 years that the boy was at home was actually consulting. The patient was here because they believed that he was bewitched by someone who kicked. The traditional healers also confirmed. So they wanted to get help from there because they thought doctors will not be able to do anything. Okay. Then the last leg on access to care is the digital. Connectivity, I think, helps us. What we are doing now is part of, I think, ways to be able to make sure that digital technology works for us to be able to share knowledge and be able to make sure that patients are getting appropriate care. However, we have Dr. Google and Matron TikTok. That's how I'm calling them. We have Matron TikTok, and when a trendsetter decides to post something on TikTok, and they have following, we have incorrect information that is going out to communities. But the biggest issue is that I am also part of this. The health system is very silent. We are not saying anything. We are not doing anything to educate the community appropriately to say this message that was sent out is actually not correct. So this is where we now have issues where patients would then decide to say, no, then I will not go to the hospital. I think I'm going to try this, what Matron TikTok then recommended. So looking at the issues pertaining to access, we then need to be able to look at what are the survivor needs, because they merge. And this is where our intervention, when we want to strengthen, we then need to be able to make sure that all these actually come together. So when you look at the 4 legs of palliative care, you realize that our patients have all these issues. They've got relationships. You are diagnosed with cervical cancer. You are 34 years old. You are married. And suddenly your sexuality, intimacy is affected. And nobody's asking you. Everybody's interested in you getting radiation therapy. Nobody's addressing this issue. And your husband now gets upset. We end up with gender-based violence. Patients and families, anxiety, depression, loneliness. Patients are feeling that I'm a burden to my family. And what I've come to realize that the minute the patient feels that I'm a burden, they would prefer to die now, even if the outcome would have been positive. Okay. Then there is the side effects, cancer treatment, because we cannot separate the treatment that we are giving patients and the side effects. And most of the time, I think we assume that I've given you chemotherapy, so you're supposed to be okay. When you have side effects, you come back to the hospital. What we have come to learn and discover is that patients will have side effects. They will stay at home until it gets worse, because there is no one who's making a follow-up. You are given a follow-up in 1 month. What happens between then and in between the 30 days when something crops up? Okay. And then there are spiritual issues. I will also not go into this because I've already highlighted that we need to be able to make sure that this is addressed. Otherwise, our patients are going to continue, come late or default. We'll call it default, but for them, they are actually assuming that they are doing what is necessary, because cancer is not. Okay. Then, because of the centralization of cancer care, which is in South Africa across the 9 provinces, patients are not able to access care, because for you to get to that, to Steve Biko, for you to get to Charlotte Maxeke, most of the people are not staying within reach. They have to take 2, 3 taxis. They have to take buses for them to get to those places. So this becomes a big issue for patients to be able to then access services. Okay, I thought I would share, I don't know how many minutes I have. I've extracted some lived experiences of patients. And we only got this because of the research that we are doing. And it made me realize that we actually do not listen. We don't give our patients time to be able to speak. Patient number 10 is saying, I was an athlete, a social athlete. I was running ultra marathons. And he even remembers the day. The last marathon was on the 30th of March. This cancer has taken away my mobility. I'm now stuck in the house and I can't even get work because I'm stuck in the house. Okay. And number 7 is saying, I was told that I have 6 months. I think this highlights the communication that we have with our patients to say, as doctors, we speak, and the patient will decide to say, do I believe this patient? Do I believe the doctor? Or I'm going to say, you are not God. The patient decides to say, you are not God. You will not tell me that I'm going to die in 6 months, and it's now 3 years. So this is a patient who has hope. Okay. Patient number 13 is a male patient. Culturally, males cannot cry, cannot complain. They are the ones who are supposed to be supporting the family. And he's saying, I am the patient. I have to act strong. Instead of them supporting me because I'm sick, I'm the one who's now supporting them. And I hide my pain because I don't want them to see what I'm going through. Patient number 4 is saying, I'm only 34 years of age, the only daughter of my parents. I was diagnosed at 33. And after diagnosis, then I discovered that I'm pregnant. And she actually said, I don't want to even go to that part of pregnancy. Okay. Then we also have carer experiences, because palliative care looks at the patient, you also look at the carer. Number 26, carer number 26 is saying, I have sleepless nights always because it doesn't make me comfortable to hear her scream at night because of pain. Pain is not supposed to be the major issue in this era in Johannesburg when someone is accessing treatment at Chris Bar. But this family carer is saying, this is what's happening. Okay. Then patient number 15, family carer number 15 is the one that usually breaks your heart. Says, my mother, now, her symptom is a foul smelling discharge. She could not go out. When we go to the taxis, I've just summarized it here. When we get in the taxis, people open windows. But the worst part is that in the home, the children, her children, now the grandchildren are saying, Mom, what is the smell? And she now has to say to the children, it's your grandmother. How do you explain this to young children? But there are ways that we can be able to control the smell for patients to be able to have some dignity. Okay. And her complaint, the carer complaint was that my mother was a regular chronic patient in a facility. Why is she diagnosed late? Why didn't they tell her that she has to do a pap smear when she's coming every day? Okay, I'm going to jump the others, and I'm coming now to strategies. How can we then strengthen care for our survivors? There is an issue of health education for me that becomes very key. And the health education cuts across for health professionals, for communities. There are families, we know that there's a family history of cancer, but we still do not make sure that the families of these patients are actually regularly screened. So there's a big gap here. And because they're also going to come late, the minute one is diagnosed, one carer was saying, it affected my mother, it affected my father, it affected my brother. Now it's on the second brother, and everybody's dying. Okay? So we also need to be able to understand, I think people need to be able to understand what cancer survivorship is. I don't think health professionals and communities are actually aware. So I took the definition by NCC, and here that actually says, in summary, survivorship starts when you are diagnosed and continues until you die. Okay, and it has to emphasize wellness of these patients. It also has to emphasize quality of life. Quality of life is what palliative care experts can be able to provide the patients, because everybody else will focus on the disease and will not look at the patient holistically. What we've also come to realize is that rehabilitation needs of our patients is actually not addressed, and rehabilitation can actually prevent some of the side effects of treatment, can also help improve the mobility and also improve the activity of daily living for our patients. The understanding of palliative care is still a problem, both in the community and for health professionals. There's a stigma. When patient is referred to palliative care, they already think that it means that I'm dying. So we need to be able to see how we can change the mindset. But the biggest challenge for me as a health professional is when a doctor then says, it's not time for me to refer a patient to you. And you can see the patient has a palliative care need. So there's a disjoint between senior doctors, consultants, most of the time do not have understanding of what palliative care is and when it is required. South Africa now is training undergraduates and postgraduates on palliative care, but there is this gap of people who were not trained in their undergraduate who now needs to be retrained, and they don't think that they need the training. So there is this gap that we need to be able to close. The other part that I feel is critical for us, patients do not live in facilities. I usually say this. So it becomes important for us when we have support groups. Support groups should be closer to where the patient is. There are community structures that you can be able to identify. Yes, when they are in the facility, it is important because there's peer-to-peer support that they do. But most of the time, I believe we need to be able to decentralize our care, including cancer care. And we need to integrate palliative care as a component of comprehensive cancer care. Patient navigation is not yet part of healthcare or cancer care in South Africa. Through private funding, we have come to see the benefit of patient navigators. So for me, I think if people are able to get patient navigators, it's going to change a lot because they have lived experiences. And okay, I've spoken about interdisciplinary teams. It becomes, we need interdisciplinary teams. Please, as a doctor, I can't work alone. I know I need everybody in the team for them to be able to make sure that the patient is receiving the necessary care that they require, because doctors are trained in a specific way. We also need to be able to integrate spirituality. I think this is where I'm really pushing. We need to integrate spirituality into cancer care because it actually affects the outcome eventually. We might be able to get our patients earlier and work together with traditional healers and the churches, not churches and traditional healers holding on to the patients until it's very late before they present to facilities. And what I think for me, what is also critical, we need to have contextualized tools, meaning that the research that we do must be able to then inform the interventions that are necessary for our communities, because my community is not the same as a community in the US. They're completely different. So I think I'm going to end here. I don't think I have time. I wanted to play this YouTube. So I'm going to send this to Kenko. Kenko, please, people can watch this YouTube. This is Musa Muta. He is a osteosarcoma survivor who was amputated at the age of 11 at Chris Anibara. He was seen by the palliative care team at the time. Nonkosi remembers the patient quite well, was seen by the palliative care team, pediatric palliative care team. The support that he received made him eventually to become an international dancer. So this YouTube was when he was actually performing at the UK Idols. I can't remember Idols or whatever, but you can watch, and he explains his story quite well. So for me, this is proof that when you support your patient quite well, we can be able to change the outcome of cancer patients. And I think I'm going to end here. Thank you very much.
Thank you, Mpho, as always. Very, very well done, and bringing us home the true stories of our patients in communities and how it affects us. We have got 3 questions we would in the chat. I'm actually going to start with a question to Megan, and that is, what is the WHO's financial role in addressing Africa's cancer burden, and what strategic framework does it propose for cancer control across the continent, the continent states? Megan, over to you. I know that's a bit of a loaded one. Is Megan still with us? Doesn't seem as if Megan is still with us. I think Megan has dropped off. Maybe I must then come in there and say that currently there's no financial support that will come to countries with regards to any, I want to say, health matter, because that's not the role of WHO. WHO is very much the role of policy and overarching frameworks. What we do have, and which is a very big problem for cancer control, and it is something I'm not sure how one will even begin to address, that is the whole concept of migration and what happens within Africa in terms of cancer control, and many of the countries that cannot actually afford the burden. That in itself is a specific problem. I would like to go over to the other questions that have been asked here by Robert. Paul, what is the South African government's financial strategy for cancer, particularly regarding the 76 cancer HIV population? Okay, I see Megan is back, but we'll ask that question to Megan just now. And then the other one that Paul is there a plan by the government, South African government, to provide completely free cancer care in the future? If you can just elaborate on that one briefly, I would appreciate. Thank you. Paul?
Thank you very much. And thank you very much, colleagues. I see the comments on the chat box. I'm not sure if I don't think I'm in the right position to speak on behalf of the government. I'm an advocate and I work closely with government, yes. So what I can say for cancer care, I think Salome, I saw Sandia is here. The services, palliative, no, cancer care services in South Africa for South Africans is free. However, we do not have access to some of the new modalities of cancer care. That's the limitation that we have. And the strategy, I'm not sure if the cancer strategy is fully funded, but I know that cancer treatment is available in most of the hospitals. Yes, we will have stockouts, but it's available. Radiation therapy, I mentioned earlier. There's limited availability that then affects the turnaround time when patients will then be or when they will be receiving radiation therapy. I'm hoping that I've covered it well based on what I know. And then the second question, I think, spoke about, was it funding for, no, care for HIV? Can you repeat again, Salome? It had to do with HIV and cancer.
If I can just get back to that question again. Um,
And it had to do, I think he was talking about the HIV was also part of the care.
yeah, what is the strategy for particularly regarding the 76% cancer HIV population? What is our strategy for cancer? If you can do that.
Okay. Again, as I'm saying, I'm not representing the department, National Department of Health, but the system in South Africa, national develops policies, yes, budgets will then be given to provinces. Provinces are autonomous, so they can decide how they plan for different programs. One of the challenges that we have had over the years, because the policy was approved in 2017, so advocacy continued, is that the HIV program is funded separately. The HIV program, their strategy, the NSP 2023 to 2028, actually did not have palliative care within the strategy. If it is not within the strategy, what they had was they spoke about quality of life, I think 88 times in the document, but there was not a single palliative care. If palliative care is not within the HIV program budget, there is no way that the HIV program is going to support palliative care for cancer patients who are, no, HIV patients who are now developing cancer. So there was no interlink between the cancer program and the HIV program. HIV program in South Africa is usually well funded. So I don't think I can answer. We are currently costing the palliative care strategy. We're hoping that the government will then be able to then say this is the amount of money that palliative care can be able to have. However, everybody talks about integration. Thank you.
If I may add to that, in terms of just my own experience of cancer care in South Africa, yes, we are currently, and as Megan quite rightly indicated in the beginning there, she was part of the impact review, and our impact review will basically allow us to make further progress with our National Cancer Control Plan and also a strategy to determine what it is that we need to do in South Africa and hopefully the costing of cancer care. The reality remains, and I think it is the reality that remains in most of Africa. Cancer is not regarded as a priority disease, and it is only through advocacy that we will ensure that cancer is regarded as a priority disease, that we start with the integration of move away from the silo approach, which was brought about by the HIV focus. And now that we have the elimination of cervical cancer throughout Africa, that we will then start with the integration and then look at how we expend money and make sure that there is an appropriate budget for cancer care holistically within communities. Megan, I'm actually going to go back to you for just to put this in perspective. There was a question that was asked here. What is WHO financial role in addressing Africa's cancer burden, and what is the strategic framework does it propose for cancer control across the continents of states? If you can just provide a perspective there, appreciate. Thank you, Megan. I know Megan was back. Is Megan still on, or has she fallen off again?
Am I audible now?
Yes, you are. Thanks,
Okay.
Megan.
Sorry about that. I'm having connection issues, so my apologies. But WHO provides support to countries, mostly in the form of technical support, meaning, helping cancer planners in the Ministry of Health formulate plans that are based on their priorities, meaning the priority conditions that you have and the best, return on investment. There is not necessarily, large amounts of funds to pay for cancer care. That has to be, to be sustainable, countries have to prioritize that. And I think that's where this advocacy piece comes in. But WHO supports countries to figure out within cancer care, within palliative care, what is your best value for money? We know everywhere cancer budgets are limited, but they are growing quickly. And if we don't plan, then they grow in ways that doesn't make sense, right? We spend too much on things that are not saving or transforming many lives. So the role of WHO is to help countries figure out what's the best return on investment, where should you invest with the funds that you have. And often that is palliative care, and that is prevention, and that is early detection, right? Because those are areas where you really have potential to make a big difference. And that's why we put a lot of emphasis on cervical cancer elimination, because we can eliminate cancer that is much cheaper than, if we can eliminate cancer, that's much cheaper than having to pay for treatment. So those are my big picture thoughts, but I think my connection's not great.
Thank you, Megan, for that perspective there. Here is a question from Pius. As a patient advocate in Kenya, how do we increase inclusion of the lived experience to better the outcomes of patients, family, and healthcare working in a net-like community? Any suggestions there from both Megan or Paul?
Thank you very much, Paris, for the question. I think that's what made me put in the quotes from the lived experiences of patients. One of the recommendations that I actually put in, I think I didn't emphasize it, was that we cannot continue to plan programs for patients and families without their involvement. I had an opportunity of talking, or maybe to say, I work with cancer survivors. I deliberately employed cancer survivors to be our patient navigators, and they are able, I can't share a journey on cancer. They can share the journey. I only have a familiar experience because my sister died of breast cancer, but I can't tell the patient what it is they will go through. So planning for which continues to be a gap, planning for communities without involvement of the communities and the patients should actually stop. We have to make sure that we involve them in what it is that is going to make sense for them. What are the gaps? They understand the gaps better than, as a doctor, I don't think I understand, but they will be able to. That's why I'm saying I work with them. I know what they tell me. In some cases, patients will say to you, you don't understand, so don't come and tell me that it's going to be better because you do not know. And they will tell you that I then have to actually tell them that I'm actually a cancer survivor and address and show them the wounds, the whatever it is that they went through. Besides involving them in this, for me, I don't think we support them. We are not offering enough support for cancer survivors. I'm hoping that I have been able to answer the question.
Megan, anything to add from your side?
I think just to add that for making good cancer plans, you have to be involved. You have to have the whole of society approach, and that means engaging with patients and advocates as part of the process. So I encourage cancer planners to think about that, and advocates and lived experience groups to make sure your voice is there at the table. It has to be part of the planning.
There you go. It has to be part of the planning right from the word go. You cannot, and I think that is a statement that we all make as advocates. We need a seat at the table. And for that seat at the table, we cannot enter from the back door. We have to be there from the word go. And that is very, very important. There's a practical question in here, and that is, how did you manage the foul smell from the fungating wound of the 16-year-old with osteosarcoma? That's very particularly going to you, Paul.
Well, thank you very much. I can't remember who asked the question, but this is a common problem. It's not only osteosarcoma. I think the quote from the carer about the cervical cancer woman with a foul smell, it always comes up. In some cases, any wound that the patient has that is infected will probably have a smell. So most of the time we use flagell to be able to pack. But ideally, you're supposed to know what organisms are growing. But most of the time, flagell will then be able, you literally crush the tablets, make them a paste, and you are able to then apply it on the wound or plug your patients who have cervical cancer just to reduce the foul smell. And there are other dressings that you can use. But in this particular case, this patient required, the wound was too big. So it required amputation, which eventually happened. Thank you.
Thank you, Paul. Any further comments? And I'm actually going to read out the comment here from Sandhya Singh, having been involved at the National Department of Health in South Africa. Participation of persons with lived experience throughout the continuum of care must be institutionalized and cannot be dependent on the goodwill of government. We do know, and I think Megan can actually support that these are also directions from the World Health Organization with regards to the inclusion of people with lived experience in all our efforts. And it therefore is very important that in our countries we literally make sure that we that we are part and parcel of the decision-making processes. That is policy development, the development of national cancer control plans, strategic frameworks, but also in our various communities that we make sure that we participate. And for that, it is also important that we make sure that everybody and that we build the capacity of our people with lived experience to be participants in these processes. We have got another 5 minutes. If there's anybody that has got a very particular question, let's read this. There's several global cancer initiatives for supporting cancer control in low middle income countries for breast, cervical, childhood cancers, and what is the role that they could be played by the WHO Africa region to have encouraged countries which have not integrated cancer care services to their health systems to align with global initiatives and integrate cancer care services into their health systems. Megan, I'm not sure if you are willing to take that one on because it is particularly for WHO in terms of the very specific regions. Maybe I can come in.
Yes, I can. Can you just repeat the question? I didn't hear the very beginning of the question.
So there are several global initiatives from WHO supporting cancer control, that is breast, cervical, childhood cancer. And then what is the role that could be played by the WHO Africa Region Office to encourage the integration of cancer services in their health system?
Yeah, can you hear me now?
Yes, we can.
Okay. So all of those initiatives are implemented through the regional office. So even if they are like a cancer program that's from headquarters, all of our programming goes to the regional office. We have Dili Isimuha in the regional office who supports all of WHO's programming on cervical, breast, and childhood cancer, and then to the country offices of WHO. So I encourage you to find out who is in your WHO country office, who is implementing work on breast, cervical, and childhood cancer, and liaise with them because they probably need to know who you are so that they can support your national government on its priorities on these 3 initiatives and make sure that palliative care is part of them. So that would probably be a key step, is to reach out to your country offices. I'm going to tell you, I don't know everybody in all the country offices. There are 9,000 WHO staff. So maybe it's worth reaching out to your office and just finding out who it is in your country office and just ask who is responsible for childhood cervical and breast cancer and how can we support them? Can we have a meeting and discuss?
And I think that's a key lesson from the session then, apart from all the various tips that we have received from Megan as well as Mpho, is that it is your responsibility also to find out who is your country person responsible for cancer control from WHO. The Mpho has actually posted it in for South Africa. We've got Dr. Joseph Mwangi as the key contact person. But for each country, there should be a country officer. So please find out. And then I'm also going to share a comment again from Sandhya Singh. Methodologies to allocate morphine to countries must be reviewed. And I take it that's a review that needs to be done by WHO, as they depend on the utilization, which does not align with the actual need due to poorly developed health systems, buy-in, and politically and strategically. So that in itself becomes another problem. And we also know about some of the shortages with regards to morphine, and then asking the question whether our essential medicines lists do make provision for the utilization of morphine, and at what level is morphine available? Is it only available at a tertiary level, or is it even available at a country level, at a community level? If we're wanting to extend palliative care to communities, we need to start thinking critically about these questions. Is there anyone else who wants to come in with a question or a comment? It seems that there's no more questions and no more comments. Thank you. Let me just see. There you go. Thank you, South Sudan. The WHO's contact officers are Dr. Moses Mutebe and Dr. Mutale. And I think that may be something at some point that we actually need to start looking at, is how do we start sharing resources between us, to make sure that everybody knows who's who with regards to the kind of things that we can share and collaborate with. We have had the session today then on palliative care, Megan focusing on the WHO framework and all the various resources that is available from WHO and from the team. Thank you very much, Megan, once again, for a very informative didactic session. And then I also to Mpho, thank you for sharing the practical aspect of palliative care and the challenges that we face. And I do want to say that the challenges that you've highlighted, I think that everybody on this call can in fact identify with the challenges that have been actually identified. There's been mention of survivorship. And we particularly, as the steering committee for this ECHO platform, I have asked and we have agreed that we will not do survivorship and palliative care together. We will do it as separate topics because we feel that the concept of survivorship is something that we need to start diving into and expanding that in terms of what is our understanding of survivorship. So we will, in our next meeting, which will then be the last Thursday of July, we will focus on survivorship. Again, we will have a didactic speaker as well as a case presenter, and we look forward to having you on that conversation as well. Thank you very much for all your participation, active participation, and ensuring that we share knowledge in our group. As always, the meetings are recorded and are available on the ECHO platform for those who were unable to join for the whole session or who actually would like to go and see all the resources again that have been shared. Thank you for everybody and have a good evening wherever you are, or a good day. Stay well. Mooi loop. Thank you.
Thank you.